My name is Meghan Parr. I am currently a student at the School of Nursing in the RN to BSN program in the University of Central Missouri, enrolled in evidence-based practice and research. Today I will be discussing emergency department crowding and its effects on an ED patient in a common demographic. Emergency department crowding is a global phenomenon affecting the healthcare for over 20 years and was intensified by long-reaching effects of the COVID-19 pandemic. ED crowding is defined by Pierce et al. As a situation where demand for emergency services exceeds the ability of an ED to provide care within an appropriate time frame. Factors that affect ED crowding can be placed into three buckets: input, throughput, and output. Input includes patient traffic coming into the ED for medical care. Throughput is the time it takes for triage, assessment, diagnostic testing, and imaging, and appropriate consults for specialty care. And output is the overall decision for disposition of the patient, which can either include to home and self primary specialty care or for admission to the hospital for further treatment. Some factors influencing input are the aging American population and lack of access to primary and specialty care that leads to an increase of lower acuity patients presenting to the ED, along with an increase of mental health and addictions complaints due to lack of community resources. Throughput delays can often be attributed to staff shortages, high patient-to-nurse ratios, and high turnover and burnout rates. Overall, the factor that seems to contribute most to emergency department crowding is the delay of the output of patients admitted to the hospital as they are boarded in the ED until room becomes available in the hospital, decreasing the ED's capacity to see and treat ED patients. Yusuf et al. 2024 states, emergency department crowding has repercussions on acute care, contributing to prolonged wait times, length of stay, and left without being seen. These indicators are regarded as systematic shortcomings, reflecting a failure to provide equitable and accessible acute care. Emergency departments have little control over input factors, as this is a community and nationwide concern, and the output factor of inpatient boarders is a health system-wide issue to resolve. So, emergency departments focus on interventions to streamline throughput and efforts to reduce crowding. Some attempted interventions in throughput have little impact or adverse effects on throughput. Hallway care, which consists of attempting to assess and treat patients on carts and chairs in the ED when ED bays or rooms are filled, has shown little significant improvement to throughput. And increased nurse-to-patient ratios actually further delays throughput and decreases patient satisfaction, which in turn increases incidence of left without being seen and left before care complete. Two throughput interventions stand out as correlated to reduction in time to provider and time to disposition, and a decrease in rates of left without being seen. Fast Track, as presented by Grant et al. 2020, is a dedicated area in the ER which focuses on lower acuity patients with a designated APRN or PA. RNs are able to increase patient ratios without decreasing quality of care due to a lower acuity. Based on my personal professional tenure, Fast Track can be limited by staffing availability, as it is typically the first area in the ED to close at nighttime hours when staff is limited. And at times, it is not used as intended due to high volume of boarded inpatients, resulting in higher acuity patients being seen in an area of care that is not set up for or always has all resources need for that acuity patient readily available. Provider and triage and standing orders by far, as presented by Yusuf et al. 2024, have the most positive impact on throughput. Standing orders allow for modification of the front-end triage workflow to include point-of-care testing, appropriate lab work, and diagnostic imaging, often alerting for a need to up-triage a patient, leading to decrease in time to disposition and and in implementation of necessary interventions in improving overall outcomes. Provider and triage, like Fast Track, allows for lower acuity patients to be assessed and treated in a designated triage area and discharged to self-primary specialty care or expedite treatment until they are able to be seen by staff emergency physicians in the ED. Common demographic to the emergency department is patients with cancer-related pain who are no longer able to control their pain on their at-home regimen. Unfortunately, these types of patients who appear clinically stable do have adverse effects of ED crowding. One such patient that I recently had was a male in his late 60s with stage 4 metastatic prostate cancer. Up to the point of his recent ER visit, he had continued to live a very active, thriving lifestyle. And then recently started to have this uncontrollable pain that was greatly interfering with his quality of life. He did have an at-home pain regimen, but it was no longer working. He had contacted his primary care provider and his oncologist, and they referred him to the ER because he had on his own began to double his at-home PO pain medication, and it still was not lasting the recommended 6-hour as needed dose. This patient presented to the ER with stable vital signs and was monitored by the triage nurses, but did have a 4+ hour wait in triage before we had room back in the ER to see him. This patient during that time was not able to take any pain medications because he did not bring any of his home medications with him, and we do not give opioids to patients in the waiting room as we are not able to have them on the monitor and safely monitor them. When he did get back to the ER, he was given several doses, 3 to be exact, of IV Dilaudid, which did work to manage his pain, but he did need frequent dosing about every hour and a half. This patient was quickly admitted to the hospital for pain management. However, there were no rooms in the hospital. This was a night where we had a high load of inpatient boarders. My patient was upset because ED carts are not comfortable. He was already in pain, and now he was going to have to spend more time down in the ER, which is louder and just quite frankly not set up for inpatient care. So this patient, I had to discuss with him the plan of care and ways we had, in fact, already expedited his care and used evidence-based practice to advocate for him and best treat him. In discussing with my patient his concerns for his plan of care, I used active listening as described in our course text to include the principles listed here and implemented my habitual practice of sit when you can to provide care, which is an initiative enacted by my previous employer. It encourages staff to sit when interacting with patients, as it has been shown to make patients feel that staff is more interpersonal in delivering care and are taking more dedicated time for their patients, and it encourages patients to be more active participants in their care. By actively listening to my patient and reflecting back to him his concerns, he was more open to working with me to form a working plan for his care. I was able to discuss with him how we had already expedited his care during his long waiting room tenure with POC testing, lab work, and diagnostic imaging with results, all before he was brought back to the ED room. This enabled him to be seen by an ED provider and admitted to the hospital within 30 minutes of rooming. Once he was calm and talked off the wall of leaving before care completed or leaving against medical advice, I was able to have a discussion with him about how the ED manages acute pain versus how, as an inpatient, they would work with him to find a personalized pain management regimen that he could continue in his home setting. According to our course text, Evidence-Based Practice in Nursing and Healthcare, A Guide to Best Practice, 5th edition, functional mastery of health ownership is the intentional, active empowerment for patients and families to own their healthcare status. And there are 4 foundational influences, which are patient perception of health, patient self-efficacy, patient social resources, and patient personal perception of the mastery of their healthcare, which is the autonomy to make decisions and responsibility to achieve wellness. By talking with my patient and actively listening to him, I was able to facilitate FMHO. I made sure my patient understood his plan of care and the reasoning behind it. I included him in the decision-making process and set some reasonable goals for his care, such as like what a reasonable expectation of pain level was. And I also was able to call his provider team in front of him. Though they weren't able to come down to the ER to see him right then, I was able to get them on the phone and get their buy-in with him listening to the care we had discussed. This gave my patient an active role and responsibility in his own plan of care of notifying me when he was reaching a level of pain that was above an acceptable, manageable level so that we could start working towards that personalized pain management plan for him. Um, do I believe there are improvements that could have been made for this patient? Absolutely. But I do believe that he did have a good outcome using all the resources available. Thank you for your time. And here are the resources that I used as a comprehensive study for my presentation.